Good morning, students. Today I'll be starting with retinoblastoma. This is very important topic for you all. It can be asked even in Viva. Okay, and even after finishing your PG, if you are preparing for PG, then you'll have a Viva MCQs also. They ask many questions on this retinoblastoma. You are seeing what you are seeing in the right eye. Right eye, you are seeing some reflex in the pupillary area. That is a white reflex in the pupillary area. It is called as leukocoria. Okay, this is abnormal. Okay, this is normal. What you are seeing, some red reflex in the pupillary area, which is when you put a torch or when you take a camera, when you take a photograph, you will see this reflex in the pupillary area, red reflex. This is normal, which is called as Bruckner's reflex. Okay, retinoblastoma, retinal tumors are divided into neuroepiblastic tumors and associated tumors. Neuroepiblastic tumors are neurosensory layer involves retinoblastoma, astrocytoma, RPE layer involving RPE hypertrophy. Phakomatosis, that is angiomatosis, retinal tuberculosclerosis, von Hippel's disease. Retinoblastoma is the most commonest intraocular tumor of the childhood. It accounts for 0.01% to 0.04% of all the diseases of the eye. The second most common primary intraocular tumor at any age after uveal malignant melanoma. And it is the third most common intraocular tumor at any age after uveal malignant melanoma and metastasis. This gene predisposition is very important. Please remember this 13q14, this predisposing gene, okay? And it heritable is 40%. It is based upon Nelson's two-hit hypothesis. According to that, first hit mutation is occurring at the pre-zygotic phase and involves all the cells. In second hit, according to that, mutation is occurring at the post-zygotic phase and it involves the retinal cells. So if it is predisposed to the pineal blastoma, then it is called as trilateral retinoblastoma and astrocytoma. Heritable retinoblastoma, it has inheritance. Risk of transmitting the gene mutation is about 50% of chances. 40% of offspring of all the survival of the heritable retinoblastoma will develop the tumor. Unaffected parents of the child with bilateral retinoblastoma with no family history have 40% chance of producing another affected child. What is non-heritable retinoblastoma? It accounts for about 60%. 40% is heritable. It is unilateral, non-transmissible. Patient is not predisposed to any risk of second non-ocular tumors. So what are the clinical presentations of retinoblastoma? Leukocoria, what I told, white reflex in the pupillary area, which is one of the commonest 60% chance of presentation is leukocoria. So any child which is born with the leukocoria with squinting presentation or anything, you should always, and if pupil is dilated, always please remember, if you have a chance of seeing this type of this, please refer to an ophthalmologist. What are the differential diagnosis for your leukocoria? First is persistent hyperplastic primary vitreous. Second is Coats disease. Third is retinopathy of prematurity. Fourth is toxocariasis. Fifth, retinal dysplasia. Sixth, incontinental pigmenti. Seven, retinocytoma. So differential diagnosis, also they'll ask for 5 marks question. Okay, please remember this and please refer to this. Okay, this is anterior primary, persistent primary vitreous. You can see the zonules which are attached to the anterior vitreous. This is posterior persistent hyperplastic primary vitreous with RD attachment is there. This is a picture of incontinental pigmenti. In the left side, you can see cicatricial RD, okay, with skin lesions. Second commonest presentation with this strabismus, which is common in 20% of patients. Always you should rule out in all childhood strabismus. If at all there is a strabismus in the childhood, you should always rule out retinoblastoma. Okay, which is the commonest presentation. First is leukocoria, second is strabismus. Third can be your secondary glaucoma, which is always uncommon, but you should always rule out. Fourth clinical presentation is unilateral iris invasion. So I was telling you in uveitis chapter also, there is an entity called as masquerade syndrome. So if it is there is a typical presentation of hypopyon, you should always rule out Behcet's disease. Okay, hypopyon presentation can be seen in Behcet's disease with uveitis. Okay, with ulcers, mouth ulcers. Okay, that is Behcet's. Then if at all there is a hypopyon, it can be even your viral keratitis can be there, or it can be your keratitis, fungal corneal ulcer also can present with hypopyon. If there is any pseudohypopyon which is very common in masquerade means it is not due to there is spillover uveitis is there. Spillover uveitis in the anterior segment, which is due to your posterior segment pathology, there is spillover uveitis, that is masquerade syndrome, or it can be due to your intraocular tumors. Okay, so fourth commonest presentation is unilateral iris invasion. It can be present as a multiple nodules, or it can be a hypopyon picture, which is always called as masquerade. It is mimicking like uveitis. Okay, masquerade is it is mimicking like uveitis. It is not due to proper uveitis, but it is something, some other pathology is there which is clicking to your diagnosis. So always be very fast in your diagnosis. Okay, something should be any small child presenting with uveitis. You should always think whether it is due to some other pathology which is causing uveitis. Okay. Fifth is orbital inflammation, which will always mimics like orbital cellulitis picture. Okay, you're seeing the right eye. Many iris nodules are there. Okay, iris nodules on the right side. So many nodules are there on the and iris on the iris anterior surface of the iris. This can be due to your retinoblastoma. This is a picture of pseudohypopyon. Okay. This also you can see very thick hypopyon. It is pseudohypopyon. Sixth presentation can be a metastatic disease, which involves the lymph nodes, brain. Sometimes, if it is involving the brain, it is the commonest cause for death. Seventh clinical presentation can be your raised ICT. It is very common in trilateral retinoblastoma. They can present with raised ICT. Okay. Eighth is less common presentation. Spontaneous hyphema can be there. Heterochromia can be there. Sometimes only unilateral dilated pupil, complicated cataract, decreased visual acuity. So always your presentation leukocoria, strabismus, hypopyon. Okay. Please be careful. Okay. Whenever you are seeing this type of patient, please refer to an ophthalmologist. Anterior segment signs in retinoblastoma, you are seeing so many iris nodules, hypopyon picture, thick hypopyon, it is pseudohypopyon. What are the types of retinoblastoma? Types, it is divided into glioma endophytum, glioma exophytum, glioma planum. Okay, glioma endophytum is more common, which tumors is growing into the vitreous. Exophytum growing into the subretinal space. Planum, infiltration occurring along the plane of the retina. Okay. There are different types of classification, and histopathology picture of retinoblastoma is very important. If you want to go to a pathology, you want to do a PG in pathology also, slides are very important. Please remember the slides, and the pattern of flower pattern also is very important in retinoblastoma. This is a picture of glioma endophytum. Okay, you can see the tumor, and on the right side you can see the optic disc. But the tumor is involving the vitreous, okay, which is white and pink in color, depending upon the, and there is a very big vessels, vascularity, high vascular tumor. Vessels run over it or into it also. It has a pattern of cauliflower-like surface. Calcification is always a pathognomic picture of your retinoblastoma. Okay, this is multifocal endophytic retinoblastoma. Many tumors are there. This will be seen only if you do an indirect ophthalmoscopy. This is glioma exophytum, which is where it growing underneath the retina. Along with that, you are seeing retinal detachment. Okay, you are seeing so many folds, 1, 2, 3 folds, which are indicating, and with the demarcation line, it is indicates that it is a retinal attachment, which becomes can be total, or even this is a funnel shaped retinal attachment configuration with presence of calcification. Calcification, calcium deposits, which are always diagnostic of exophytum. Glioma planum is also called as diffuse infiltrating type of tumor, which also can present as a type of uveitis. What are the modes of spread? It can spread in eye or metastasis also can occur. So how does it spread? How does it cause metastasis? Along with the optic nerve, it can go to the brain through choroid and sclera into the orbit. Vitreous can be filled up. Iris can be studded with the nodules. In the anterior chamber, it can present with the pseudohypopyon. With KP, pseudokeratitis, aqueous seeding and all, it can spread to different organs. Now, what are the stages of retinoblastoma? First stage is quiescent stage. Quiescent stage is very quiet. There are no presentation of all. So that is called as quiescent stage. Second is glaucomatous stage. There is enlargement of the eye. Proptosis can be there. Sclera may give way at the limbus or intracalary region. Third is stage of extraocular extension, which is extending into the orbit. Fourth is stages of metastasis. What is the pathology? Predominantly in the inner nuclear layer, you can see how is there in the inner nuclear layer. You can see the arrangement of cells like pseudo rosette picture, which is very important. Here you can see cluster of 10 to 20 deep staining cells around the blood vessels. Clustering is because of the dependence of the cell for nourishment of blood vessels. Necrosis is due to outgrowth of the blood supply by the neoplastic tissue. Second is true rosette or pseudo rosette. Two type of pictures you can see. So true rosette, it is called as flexner intestinal rosette, where you can see a group of large columnar cells arranged in the radial manner like spokes of wheel in a palisade form around the central cavity, bordered by fine limiting member. This is a picture. Okay, you can see large columnar cells with cavity with palisade arrangement of the cells with the limiting layer lining will be there. This is high differentiated tumor, which are very characteristic of retinoblastoma. What is the classification? Classification is based on Rees-Ellsworth classification. In group 1, it is very favorable tumor. Favorable tumor means it is A, group 1A, there is solitary tumor which is less than 4 disc diameter, which is at the equator or behind the equator. B is multiple tumors or none or more than 4 disc diameter in the size and all are at or behind the equator. Group 2 is favorable. Group 2 favorable A, there is a solitary tumor 4 to 10 disc diameter at or behind the equator. B is multiple tumors 4 to 10 disc diameter in size behind the equator. Group 3 is doubtful. Any tumor which is anterior to the equator. B is solitary tumor which is more than the 10 disc diameter behind the equator. Group 4 is unfavorable, multiple tumor, some or more than 10 disc diameters. B is any lesion extending anterior to the ora serrata. Group 5 is very unfavorable, which is very massive tumor involving over half of the retina. B is vitreous seeding. How is the mechanism of glaucoma in cases of retinoblastoma? You can see there is rubiosis aridus, which is associated with highly vascular tumor in the posterior pole. Second, due to massive exudative retinal attachment with pupillary block and causing angle closure. Third can be combination of both, rubiosis leading to high vascular tumor. Second is due to RD. Fourth can be rarely due to uveitis. These are the 4 pathologies which leads to a secondary glaucoma. So what are the diagnoses? Test for confirming the diagnosis. CT is very important, which shows there is calcification. Ultrasonography denotes the lesions into which either solids or cystic. Even can you detect the tumor as small as 2 mm in diameter. MRI can demonstrate infiltrative spread along the optic nerve. Subarachnoid seeding, involvement of the brain, and helps to know the extent of the extraocular extension after the radiation and after chemotherapy. What are the diagnosis? How do you detect it? Test to detect the metastasis is first is bone marrow aspiration. Second is lumbar tap and CSF analysis. C is ancillary test enzyme analysis is very important with neural specific analysis levels. If you see in the aqueous, that indicates retinoblastoma. So what are the calcifications you can see? One of the commonest calcification, if you see, I told it's a retinoblastoma. Second commonest differential diagnosis for the calcification are phthisis bulbi, phlebolith, optic nerve mangiomas, Sturge-Weber's angioma. This is if your Viva question, calcifications, and it can be asked also in your Viva for your PG entrance also. Please remember this. Teratoma, Coats disease, toxocariasis, toxoplasmosis. What are the modalities of treatment? First and commonest, first most is the discussion with the parents. You should always reveal what is child is developed and what is the treatment of choice for that. Because you have to do enucleation only if it is a stage 4. Okay. Why? Otherwise you want to save the metastasis to brain. Third is genetic counseling, regular follow-up. Fifth is prognosis. So treatment of choice is only enucleation. So whenever we ask what are the indications for enucleation, relative and absolute indication. Absolute indication for enucleation is always retinoblastoma. Okay, your answer should be retinoblastoma only. Second treatment is external beam irradiation. Third is radioactive plaques. Fourth is photocoagulation. Fifth is cryotherapy. Sixth is chemotherapy. For smaller tumors, okay, laser photocoagulation or transpupillary thermotherapy. For tumors, what are the indications for this? For the tumors which are posterior to the equator and for the tumor size which is less than 4 diameters and it is a 2 millimeter and less than 2 millimeter in thickness with no vitreous seeding or optic nerve involvement, you can plan for laser photocoagulation or transpupillary thermotherapy. Second is cryotherapy. For tumors which are anterior to the equator, tumor size is less than 4 millimeter in diameter and less than 2 millimeter in thickness with no vitreous seeding or optic nerve involvement. For medium tumors, it is brachytherapy. For tumors no more than 12 millimeter in diameter and 6 millimeter in thickness, unsuitable for photocoagulation or cryotherapy, cobalt 60 or iodine 125 plaques are always used and they are placed on the sclera for brachytherapy. For medium tumors, the second option is external beam radiotherapy. Dose of 3,500 to 4,500 rads to be given over 6 weeks. Preferably avoided as it carries a high risk of complications like cataract, radiation retinopathy, risk of inducing secondary malignancies like osteosarcoma. So what is the treatment for medium tumors? Again, chemotherapy. What are the agents used? Vincristine 50 microgram per kg IV, adriamycin 2 mg per kg IV, cyclophosphamide 20 mg per kg IV, 21 days interval and it is given for 15 months. For larger tumors, what is the treatment? Larger tumors, chemotherapy is used to shrink the tumor. It is called as chemoreduction, then followed by local therapy. First option for large tumors is again enucleation. Here, large piece of optic nerve should be obtained and sent for histopathology examination, usually done in cases of tumors with poor visual prognosis when chemotherapy is inappropriate and when there is an increased risk of recurrence is there. Treatment based on presentation. Retinoma, it is regular observation. If it is a unilateral retinoblastoma, non-heritable, then it is external beam radiation. Small posterior pole involvement is there, then it is laser therapy. If it is a bilateral symmetrical group 1 and 2, then it is chemotherapy, thermochemotherapy. Group 4 and 5, it is triple chemotherapy. It is based on the presentation. It is bilateral asymmetrical, then worse eye with no visual acuity, then it is enucleation only. Vitreous seeding, diffuse, then it is chemotherapy. Localized, then unilateral, it is enucleation. Sixth is diffuse infiltrating, then it is enucleation only. What are the prognostic factors? Overall mortality rate is 10%. What are the prognostic factors which will tell whether we have what we have to plan? So if there is optic nerve involvement, 8% MR if not involved, then 65% if involved beyond cut middle rectus, then 15% if lamina propria is involved. If there is choroidal invasion, then it has a very adverse prognostic effect. Depending upon the tumor size and location, small tumors have better survival rate of 70%. Older children have poor prognosis. If there is cellular differentiation, well differentiated tumor having of MR of 8%, while poorly differentiated tumors of 40%. What are the tumors of uvea? Tumors of uvea are iris melanoma, iris nevi, iris cyst, ciliary body melanoma, choroidal hemangiomas, metastatic carcinoma, intraocular lymphoma. Most commonest primary intraocular tumor in adults, it is choroidal melanoma. It presents in sixth decade of life. It can present with symptoms like reduced visual acuity, visual field defect, photopsia. It can be even asymptomatic also. Choroidal melanoma, it can present as elevated subretinal oval-shaped mass, brown color. Secondary exudative retinal detachment is very common in this. It may be associated with cataract, uveitis, and secondary glaucoma. This is a picture with secondary melanoma with secondary exudative retinal detachment. This is mushroom-shaped choroidal melanoma. You can see mushroom-shaped inside in the vitreous and subretinal space. This is a large choroidal melanoma. Choroidal melanoma investigation is binocular indirect ophthalmoscopy. Ultrasonography, most accurate in detecting the tumor in hazy medium. CT scan or MRI scan helps in detect the extraocular extension. Fourth is general physical examination. It's very important to detect a primary carcinoma. This is a B scan of large choroidal melanoma. Choroidal melanoma treatment depends on the size, location, extent of the tumor, state of the fellow eye, general health and age of the patient. Okay, this is histopathology. So you should differentiate when they give the slides of histopathology slides. You should differentiate whether it is choroidal melanoma or retinoblastoma. So in a retinoblastoma, you have spindle-shaped cells. I showed you that two types, true rosette and pseudo rosette picture. That is flexor intestinal rosette type of picture will be there. Choroidal melanoma, you have a typical characteristic type spindle shaped cells. They are spindle A usually which is benign. Spindle B has excellent prognosis. C is epithelioid cells which has the worst prognosis. D is intermediate cells which has features of both spindle and epithelioid cells. Treatment is brachytherapy for the tumors which are less than 10 mm in elevation and less than 20 mm in basal diameter. Tumor regression starts about 1 to 2 months after the treatment. So this is brachytherapy. Tumor is first, it should be outlined with methylene blue. They'll mark the tumor. Okay. The same area is again outlined with diathermy. Then the dummy applicator will be temporarily kept over the tumor and pre-placed sutures should be inserted. And then it is replaced with radioactive plaque of the same. Choroidal melanoma treatment is first TTT, transpupillary thermotherapy with a diode laser to induce hyperthermia. The tumor which is close to fovea or disc, complementary to brachytherapy. Enucleation for the large tumors with no use, very poor vision. Choroidal melanoma extension. What is accentration also? They may ask a viva question. Accentration of the orbit in patient with extensive extraocular tumor. Palliation for the patient with metastasis helps for the prolonged life. This is conjunctival melanoma. The left side you can see a pigmented conjunctival melanoma. Okay, with vascularization. Okay, and this is amelanocytic conjunctival melanoma. Okay, amelanocytic is few melanin pigments are there, so it is white in color. This is conjunctival tumor, limbal dermoid. This is also they may ask in your viva or even PG entrance also limbal dermoid picture they may ask. Okay, please remember this. Then this is conjunctival epidermoid picture in the right side. This is conjunctival ocular melanocytosis. Okay, this is nevi of ota. This is why it is important nevi of ota. Why? Because it is more prone for glaucoma, secondary glaucoma. So these patients and all, if you see any patients with the pigmentation in your conjunctival melanosis along with pigmentation on the one side of the face and all, those patients you can refer them for IOP checkup. Okay, the right side you can see nevi, conjunctival nevi. All conjunctival navel, if at all there is increase in the pigmentation, they are growing, they are increasing the size, okay, size, pigmentation, and if it is in the side of fornicis side and in the limbal side, then you should they are more prone for malignancy. So those nevi we should always at least you should do the observation. If it is increasing in the size, if they're abnormally growing, and if there is any thick pigmentation, size is it is not regular, irregular in size. So these are the signs of malignancies. So you have to always observe them. And if at all if it is increasing, then you can do IDO and see fundus whether there is again there is any melanoma growing in your posterior segment. So these are iris cyst. Primary iris cyst, should you always remember, this is one of the side effects of your pilocarpine also, primary iris cyst. Okay, side effect of your pilocarpine. Secondary iris cyst, picture you can see in the right side. These are the iris tumors, iris leiomyoma. This is iris inflammatory granulomas which are in the inferior part. Thank you.